Hi, good evening, everyone. So, on the behalf of Signutra, I welcome all of you to this critical care lecture series 2. We know that relevance is one of the key terms related to re-inform the teaching and learning of science. And number 2 has a relevance of speed of light. And that's how we can disseminate the knowledge and create more awareness. And today we are going to discuss about a very important topic, steroids and nutrition ARDS. And with this, we have our chairperson, Dr. Arun Bansal, who is a professor, Pediatric Critical Care Unit, Department of Pediatrics at PGMIR, Chandigarh. He has more than 100 publications to his credits in journals of national and international repute. Specific area of interest, pediatric ADS, nutrition and probiotics. I welcome Dr. Arun Bansal. We have Dr. Ankit Mehta, who is going to moderate the scientific session. Dr. Ankit Mehta is working as pediatric intensivist at Zydus Hospital, Ahmedabad. His areas of interest are pediatric trauma, immune response synthesis, and functional echo. He has been awarded and recognized by a couple of more awards, like second prize V. Bal Gopal Raju Award in Pedicon 2017, Best Young Achiever Award in Chandigarh, and oral paper presentation in Aspenic 2017 in Lisbon. I welcome Dr. Ankit Mehta. And we have our speaker, Dr. Rajalakshmi Iyer, who is pediatric intensivist at Government Medical College, Thrissur. She has done her MBBS from Government Medical College, Thrissur, MD Pediatrics from Government Medical College, Kozhikode, and DM from PJMR, Chandigarh. Her area of interest is PRDS, septic shock, quality improvement, and she has published a couple of articles in many index journals. So I welcome Dr. Rajalakshmi here also. So with this, I would like to hand over the scientific session to Dr. Ankit Mehta. Over to you, Dr. Ankit.
Yeah, thank you, Dr. Chetan. So good evening, all of you. So this is the second session in the critical care lecture series. So we have planned around 14 sessions in the session, and each of them will be a different important topic in the critical care area. And here you will have a person who will be speaking along with a mentor who has had enough experience to enlighten us all that what are the current practices and what he has learned over the experience of last 20-30 years. So I welcome obviously Dr. Arun Bansal sir and Rajalakshmi. And I think the important part here is the steroids. So what I have understood in my small span of 9 years, steroid always is like a magic bullet. We think steroids will go and the patient will improve. So that is the general conception, but I am very clear that Rajalakshmi is going to give her clear view on both the sides of the coin, and at the end of the session we should be clear that whether we should use it or not, we should have a clear idea. So over to Dr. Rajalakshmi for enlightening us during this next 30 to 35 minutes.
Thank you so much, Ankit. So I thank APCC for this opportunity, and for me it's an honor that it's a privilege that I'm sharing the screen with both Ankit, who's one of my most inspiring seniors during DM, and Bansal sir, who's been a mentor to me for all of these years. So let's just start quickly. I'm just going to share my screen. Just a minute. Just a second. One moment. Okay, I'm just starting the slideshow. Okay, so yeah, so let's just go straight to our topic. And while the call out said steroids and nutrition in pediatric ARDS, we are going to be focusing on steroids in pediatric ARDS and how we would use them in our armamentarium. So the overview would be, we talk a little bit about pathobiology and targeted treatment of pediatric ARDS. We'll discuss a little bit in the evidence in favor of steroids, evidence against steroids, and when and how, if we are going to use steroids in pediatric ARDS. So since this is probably the first session in pediatric ARDS in this series, let's just talk a little bit about the diagnosis of pediatric ARDS, just a short review for all of us. So all these years we used the Berlin definition to classify pediatric ARDS, but now we have our own. So in pediatrics we have the PALIC criteria, which is what I've displayed here on screen. You know that, so basically what PALIC did was it showed us it gave us our very own criteria to diagnose pediatric ARDS, which is, and definitely ARDS in children is different from that in adults. So basically, we are sticking with a few things as the adults. That is, we are looking for an insult within 7 days of its origin. We need a respiratory failure which is not fully explained by cardiac failure or by fluid overload. Unlike in adults, we're not looking for bilateral heterogeneous infiltrates. Rather, we're looking for new infiltrates which are consistent with pulmonary parenchymal disease. Now, oxygenation criteria is where PALIC totally differs from all of the others. And we basically stratify them into two. So you could be on non-invasive ventilation or invasive ventilation. If on non-invasive ventilation, you can use either the PF ratio, or which is the PaO2 by FiO2 ratio, or the SF ratio, which takes away the need for an arterial blood gas analysis and basically just uses the saturation over FiO2. And these two criteria would be used when the child is on non-invasive mechanical ventilation on a CPAP of more than 5. If we go to invasive mechanical ventilation, because we have a mean airway pressure, we would rather use, and probably a better stratification would be using the oxygenation index or the oxygen saturation index, classifying it into mild, moderate, and severe. So severe ARDS being anything more than 16. In addition, what PALIC did was they included 3 sets of disorders which the adults do not need to address. One is cyanotic heart disease, chronic lung disease, as well as left ventricular dysfunction. So this is why probably PALIC would, so PALIC is still undergoing its tests with respect to how it stands against, say, the Berlin definition. But anyway, as of now, it seems to be working for us, and I'm are following. So let's just briefly discuss the pathobiology of pediatric ARDS. So this here, what we see on screen is a normal looking alveolus. So we see an alveolus which is white in color, signifying that it's filled with air. It's lined by a beautiful lining of type 1 and type 2 pneumatocytes, and it's got a nice layer of surfactant around it. There are very few macrophages. There's virtually no debris in the alveolus. We then have a vessel, the pulmonary vessel, the pulmonary capillary, and we can find that it's just gas exchange which is happening through both of these with very little transudation of fluids. Now, what happens in ARDS as such? So basically, that beautiful looking alveolus is now converted into this mush, which is filled with a lot of fluid, which is signified by this blue colored thing which we see. In addition, we see that there's a lot of debris, there's a lot of stuff which is now happening to this particular alveolus. So basically, we have activation of an uncontrolled inflammatory milieu, which you can see with this influx of alveolar macrophages, cytokines, chemokines, activated neutrophils, and a ton of protein-rich fluid, which all of these would induce. In addition, there is injury to the alveolar epithelial as well as the endothelial permeability barrier, as a result of which you see that lots of things go across these membranes much more freely than they would otherwise. In addition, you can also see here, as this arrow points, that there's destruction of these pneumatocytes, and that surfactant layer, which was so beautifully lining that alveolus, is nowhere to be seen. So there's a lot of dysfunctional surfactants now floating inside the alveolus rather than lining it and giving it some degree of surface tension as it should normally. In addition, as is very evident, we will find that there's impaired alveolar fluid clearance, and the alveolus is now filled with a ton of fluid. So essentially, this is what we see. There's one more point here which we probably should note, because this becomes important in management, especially in the topic that we're discussing today, and that's the fact that there's fibroblast proliferation happening. So in the previous figure, we saw that there were no fibroblasts there at all. Now there are fibroblasts which are creeping up into the lung. So in our wrestling ring, we have this formidable opponent called pediatric ARDS. Now the shining star of our arena, thankfully, is the open lung strategy, which has stood its test of time almost 20 years now. We use low tidal volumes of between 3 and 8 ml per kg, depending on how severe the ARDS is. We use an optimum PEEP. We do not use sustained inflation recruitment maneuvers. We use incremental PEEP titration, try to get to the optimum PEEP, drop the FiO2s down, and keep the lung as open as possible, thereby trying to minimize the damage that we cause to the alveolus and the various traumas that can be present. In addition, the next thing, which probably is something we practice on a daily basis, fluid restriction. So multiple studies in both pediatrics and adults have shown that keeping the fluid balance either at 0 or negative is possible. Definitely less than 5% is something which would help in clearing the lung of these children with pediatric ARDS. So they have leaky capillaries all over the place, but the lung probably is one of those organs which bears a big brunt of this fluid overload. And it would be a fluid restrictive strategy, fluid removal strategy, and de-resuscitation are things which help in salvage of children with pediatric ARDS. We then had a bite of the pie of neuromuscular blockage. So a while back, we had a trial, we had the Accurasis trial, which told us that, yeah, NMBAs or neuromuscular blockage is good. But now we have recently had the Rose trial, which said that, okay, not so much, not that now we use all of these lung strategies and fluid restriction in place. Probably NMBAs may do more harm than good. So we're sort of going a little away from that now. Prone positioning is something which in the adult world has definitely shown benefit, and we recently had the Perceiver trial results published showed that there was definitely a mortality benefit. So after the open lung strategy, it's probably Perceiver which any kind of mortality benefit. Of course, there are a lot of proponents who speak against this as well, but not so much against, but prone positioning is something the adults definitely do all the time. Not sure how many pediatric ICUs follow it. Early in the stage of ARDS. We think about it a little later, but maybe the time has come for us to think about it otherwise as well. Now, all of these are time consuming. We have to wait. And we are the generation, at least my generation is the generation of instant gratification. But this instant gratification thing, I'm glad to say, has not started just now. It started a long time back. And we are all on the lookout for that one particular magic bullet, as Ankit said, which is going to cure ARDS, just relieve us of all the misery of having to go through all of this. So we've done a lot of work in it. We tried surfactant. So as we talked about earlier, so there was destruction of the surfactant inside the alveolus. Akin to so most of the studies in pediatrics either come from neonatal intensive care or from adult intensive care. So we sort of took a bite out of the little ones, and we thought that maybe surfactant administration here would be beneficial. They did show some degree of lung injury improvement, a little bit of oxygenation benefit, but then as such, there was no mortality difference in those who received surfactant and those who did not. And the largest of these trials has recently come out, the Calypso trial, and there is no benefit to administering surfactant. In addition, it's super expensive, so it's probably not something that we would try to do on a daily basis. Of course, steroids, so the cheap magic bullet, which we hope. So steroids have been the subject of interest for the last 50, 60 years. The earliest description by Ashbrook of ARDS, even in that particular case series, they used steroids in, I think, around 9 patients, and 2 of them, they definitely thought that there was benefit. Of course, those are very small numbers and nothing to be proud of, but anyway, the interest in steroids has stemmed for such a long time. We'll discuss this further on in this talk. Inhaled nitric oxide, because we all know pulmonary arterial hypertension is probably a big part of bad pediatric ARDS. So as of now, there's no study which has definitely shown a mortality benefit, but then in those whom we can document pulmonary arterial hypertension, it is an option. Of course, it's an expensive option. It's not there in most places. Very few centers have good access to inhaled nitric oxide. So it becomes something which is limited and limited to a very small cohort of patients as well. So let's now go through the stages of ARDS, because the rest of our premise is based on these stages. So the first stage is the exudative stage, and as you can see, this is an alveolus which is very similar to the one I'd shown in the first slide. So you have a lot of exudate which is entering the alveolus. The alveolus is wet, it's got a ton of debris, it's got a lot of macrophages inside. All the barriers here seem to be broken down. And this usually lasts for the first 72 hours of this disease. We next enter the fibroproliferative stage, in which you have fibroblasts slowly creeping in. Most of the water now starts to get reabsorbed. Ideally, the child should start getting better somewhere here. So most of the debris starts to get cleared over here. The alveolus starts to look like it's doing a little better. And this lasts between around 3 to 7 days. And this 7 days is the reason why, so theoretically, if you go by pathology, we expect this proliferative phase to last till around day 7. And we expect that there should be some sign of improvement around day 7. And this is the reason why many studies take day 7 as one of those points where they see if their intervention has worked. After this proliferative phase, the kid may go either way. So the child may recover, in which case we are all happy, everything seems to have worked. Otherwise, the child may go into this horrible phase of fibrosis, in which those fibroblasts start to proliferate and the lung will undergo changes which may lead to a chronic lung disease. So we are not very sure which of these phases a kid is, which direction the kid is definitely going to go to. And this is one of the reasons. So the main reason we talk about this is dysregulated systemic inflammation. So we say that it's this disordered inflammation in ARDS which is going to decide whether this child is going to recover or not recover. So if it's regulated inflammation, the kid is probably going to recover. If it's not, then probably this child is not going to do that well. So our response to inflammation would be divided into a multitude of things. You have the host defense response, which comprises inflammation, coagulation, and tissue repair. There could be an acute phase reaction in which our markers of inflammation, like CRP, fibrinogen, ferritin, all of these undergo changes. There could be a serum sickness-like syndrome. You have pain, and you have stress. So the stress is going to release a lot of hormones into the milieu, the stress response hormones, the acute response to any kind of stress, which will also play a role in inflammation. Now, as part of this host defense response, we have molecules like cytokines and chemokines being released into the circulation, the chief of which are TNF-alpha, IL-1 beta, and IL-6. These are probably the most studied of these cytokines and chemokines in the inflammatory response in ARDS. If this response goes right, we end up having a resolution. If it goes badly, we would end up having an ARDS and a multi-organ dysfunction. So let's just see how that negative response would go. So basically, if you have a protracted and exaggerated inflammatory response, you could have pulmonary manifestations like increased permeability, unrestrained coagulation, and fibroproliferation. You could have increased number of neutrophils and albumin inside your bronchoalveolar fluid. You have a failure to improve the gas exchange and mechanics, and you have ventilator dependency, all because of the fibrosis we were talking about earlier. Now, what happens systemically? We all have seen this multiple times. You have systemic manifestations leading to systemic inflammatory response syndrome, which could lead to distant organ failure. So the kidney, the CNS, the heart, all of these are going to be affected. You end up in multi-organ dysfunction, increased vascular permeability, which leads to a positive fluid balance. And this goes into a vicious cycle, leading to more distant organ damage. And of course, if you have a long drawn out inflammatory response and it's not working properly, you're definitely going to be more prone for nosocomial infections as well. So basically, if the immune response is not regulated, we would end up going into this particular cascade, which definitely does not look pretty and is not going to be good for our kid either. So now let's just talk about how steroids work in inflammation before I go on to the more controversial part of this talk. So corticosteroids at low doses, I just want to bring this up front. So in inflammation, it's low dose steroids which work. Higher dose steroids have other effects like immunosuppression. So it's low dose that I'm talking about right now. So the corticosteroid, the glucocorticoid binds to the glucocorticoid receptor alpha, which then goes and binds to the DNA and leading to transcription. Now it can lead to trans activation or trans repression, as well as cis repression, and each of these would have different effects, different actions. So what I want you to focus on is this portion, this trans repression phase, and at this point, this glucocorticoid and receptor complex would mitigate the effects, downregulate the nuclear factor kappa beta, so the NFK beta molecule, and thereby produce fewer cytokines, chemokines, and may regulate the immune response to a more favorable degree. So this is the premise on which we use steroids in any inflammatory condition and in ARDS as well, because dysregulated inflammation seems to be our big problem. We would probably use it because of this. So we'll come to more on this afterwards. Now, so I'm sure when you saw the topic of this, evening, that is steroids in pediatric ARDS, I'm sure that a big part of the audience just raised one eyebrow skeptically and said, I don't believe in it. It just doesn't work. It's just a load of nonsense which people want to, propulgate. While there is the other group who would go, okay, steroids seem to work otherwise. So basically, I'm just going to be the devil's advocate for either side. I'm just going to put the evidence forth for both sides, so the pros and the cons of it, and then we can make a decision at the end of the talk as to which way we would go. So yes, steroids work. So this is that part of the talk in which I'm going to present evidence which says that steroids probably have a beneficial effect in pediatric ARDS. So we'll just quickly go through a few studies which support this particular theory. So the first of these, and these two people, so Umberto Migliori and Gilali Anane, are two people who have probably dedicated their lives to glucocorticoids and ARDS and shock. And this is one of those first studies which really brought out the point that maybe low-dose steroids and prolonged corticosteroids may be beneficial. So what they did was they analyzed plasma samples of 28 patients with ARDS, and they looked at the outcome at 10 days. They classified them into improvers, non-improvers, survivors, and non-improvers, non-survivors. So this is at 10 days. And what they found was basically that there was a regulated and a dysregulated inflammation which was happening. So they found that in improvers, their cytokine levels were falling, and there was a reduction in the nuclear factor, so NFK beta binding. As a result of which, so they found that in those in whom there was a regulated inflammation happening, these NFK beta levels fell with each progressive day of ARDS. In non-improvers who were survivors, there was a sustained elevation in cytokine levels, and this drop happened much later. While in non-improvers who were non-survivors, it just did not happen, and they just went into this dysregulated phase of inflammation, and they just could not come out of it. And they found that this was much more in the non-survivors than the survivors, and this was much more, dysregulated inflammation was much worse in those who did not improve on day 10. They found again that if methylprednisolone was administered to this kind of a group, so this was another group in which they administered it, they found that those who received methylprednisolone sort of mimicked this regulated pathway, while those who were on placebo just went all over the place, and it was more similar to the dysregulated inflammation which we saw. So basically, this particular study, it brought out the ability of this glucocorticoid receptor complex to regulate NFK beta, and that this may be critical for resolution of inflammation in ARDS. And this was the rationale of use of prolonged glucocorticoid treatment in early ARDS. So now I would like to put it out at this point that there were multiple studies in ARDS before this. We're not going to discuss all of them in detail, obviously, but then there have been studies in which steroids were started late, steroids were started early, short courses were given, long courses were given, high and low doses were both used. So basically, with time, so by the time around say 15 years ago, the concept of low dose steroids started coming, and this paper was probably one of those which was pivotal in changing how we approach steroids in ARDS. So now the same group, they went and did an RCT, and this is again one of those practice-changing sort of papers because it showed remarkable results. So they it was a multicentric study in the US. They randomized 91 patients in a 2:1 fashion to methylpred versus placebo. Methylpred was given at a low dose in a continuous infusion of 1 mg per kilo per day, and the duration of therapy was 28 days, and there was a taper over 28 days as well. Now, one thing here is that they diligently avoided paralysis, and they had very strict infection surveillance as well. Now, basically, there are two tables which are going to come here, which tell you the outcome measures. And in all of these outcome measures, extubation, lung injury scores, PF ratios, PEEP, except for mortality, the difference in survivors and non-survivors, there was not much difference between these two groups on day 7. And finally, when they compared duration of mechanical ventilation, length of stay, ICU mortality, hospital mortality, they found that the group on methylprednisolone fared much better than the group on placebo. Now, this was one of those studies which have been quoted, multiple times in multiple meta-analysis in support of steroids. They also found, so they did survival analysis as well as probability of duration, so the estimation of duration of mechanical ventilation. So the red graph is the one on placebo, and the black graph is the one on steroids. So they found that the chances of a shorter duration of mechanical ventilation was there on those with steroids, and the probability of survival was much higher in those on steroids than in those on placebo. Now, the mortality benefit was just approaching, so it was around 0.07, so it was a reasonably good one as well. So this was one paper which people have quoted, time and again in favor of steroids. So this was again way back in 2007. So we are not going to go through this. You may go through it at a later time. So basically, I just want to say that a ton of studies were compared on a lot of parameters, most important of which were hospital mortality, reduction in inflammation, improvement in PF ratios, reduction in mechanical ventilation duration, and reduction in ICU stay. And to summarize the results of all of these studies, They showed a significant improvement in PF ratios, a significant reduction in multi-organ dysfunction scores, a reduction in duration of mechanical ventilation and ICU stay. And this sizable reduction was seen more in ventilation days, so there was a difference of almost 6 days, and in ICU stay days by almost 7 days. So this basically they compared a ton of studies and they showed us, so they compared around 7 studies with both early as well as late steroids, and they showed us that in those who tapered, so those who started early and those who tapered, this kind of a difference was definitely there. The ARDS NET trials also analyzed the efficacy and safety of corticosteroids. So this was an RCT. They had a total sample size of 180, and they randomized between 7 and 28 days of ARDS, placebo versus methylprednisolone. So again, it was a continuous infusion of low-dose methylpred. They found that there was an increase in the number of ventilator-free, ICU-free days in the first 28 days of treatment, and no increase in nosocomial infections. But there was an increased death rate on those who were started on steroids after 2 weeks, and there was a trend towards increased neuromyopathy on those who received steroids. There was no difference in 60-day mortality between these two groups. The same paper was actually criticized by another person in the same group. So they did say that let's not generalize these findings to the rest of ARDS, but this was what they found in this particular trial. The SCCM and the ESICM did their own meta-analysis before releasing the surviving sepsis guidelines in 2017. And in their meta-analysis, they found that for both mortality as well as for ventilator-free days, both favored steroids. And they said in their practice paper that it reduced mortality and it increased ventilator-free days. And they recommended steroid therapy for patients with ARDS with a PF ratio of less than 200. Now, this is a new study, which actually was very interesting to me. So this was an open-labeled RCT, which was conducted very recently. So I think it was around between 2015 and 2017. And it was an open-labeled RCT, which recruited 277 patients. There was so they compared dexamethasone against controls. So the controls did not receive anything. They did not even receive a placebo. They just received conventional treatment. More than 75% of this cohort was either sepsis or pneumonia. They used 20 mg of dexamethasone daily IV for 5 days, and then they tapered it to 10 mg daily for the next 5 days, and they discontinued steroids at extubation. Now, this study, surprisingly, so even the investigators did not expect to find much of a difference, but they found that there was a definite difference in the ventilator-free days between the two groups of almost 4.8, so between 4 and 5 days between the two groups, and all-cause mortality at day 60. So day 60 all-cause mortality, they took as a marker that this was probably not a biased study at all, because these patients were probably not in hospital by then. So there was a difference of almost 15% in the mortality between the two groups. And both of these, with no increase in the number of, no significant difference in the number of adverse events. And the only adverse event that they were a little more worried about was the hyperglycemia, which they saw in the dexamethasone group, a little bit more than the control group. But ultimately, you can see here that there isn't much difference in that either. So this study actually came as a surprise to even the investigators. They didn't expect such mammoth results because of this. But one of the postulations that they have is that dexamethasone is a pure glucocorticoid. There's no mineralocorticoid action. There's no fluid retention, which would likely happen with dexa, as opposed to, say, methylpred or hydrocortisone, which have mineralocorticoid action as well. And dexa is a long-acting steroid. So it is something, so they believe that this one particular dose may do well and merits further investigation. So this DEXA ARDS study is a recent multi-centric study which seems to have shown benefits with steroids. And what about pediatric ARDS? So in pediatric ARDS, we have cases, we have case reports, all of which are in favor of steroids. So now let's come to the other group. So this is probably the larger part of the audience, I think, the ones who are going, no way are we giving steroids to our children. So there was one meta-analysis in corticosteroids in influenza-associated ARDS. It analyzed close to 6,000 individuals, but they were mostly observational studies, many of them retrospective. And it showed that the mortality was higher by almost 1.5 times and incidence of nosocomial infection by almost 3 times in those who received steroids in influenza. So this paper came from Taiwan, and they spoke very vigorously in favor against steroids in influenza-associated ARDS. There aren't too many studies as such in adults which tell us steroids are bad in ARDS. We have studies in septic shock, but we don't have too many in ARDS. But pediatric studies, on the other hand, have another thing to say. So the only published randomized controlled trial was by Diego et al. And this is their pilot version. The final version is not yet out. So they recruited around 35 children, randomized them almost equally to steroids and placebo, and they found that there was no difference in the length of mechanical ventilation, ICU stay, or mortality between any of the groups. There was a large series, it was an observational single center study, which had 169 patients, and it was a clinician driven thing. There was no protocol as such. So they just saw different steroids. So there was hydrocortisone, methylpred, and dexa, and various combinations of those. And what they found that there was higher mortality, fewer ventilator free days, and longer duration of ventilation in survivors in unadjusted analysis, and they didn't find any difference in subgroups either. So basically, with all of this theory, we did a study at PGI in which we randomized, so we did a randomized trial on low-dose methylpred versus placebo in pediatric ARDS, and we had a total sample size of 73, we had a total number of 73, with 35 in the steroid group and 38 in the controls. We followed the Medjugorje protocol of 1 mg, and we gave that for 7 days and tapered it off over the next 7 days. And baseline characteristics were very similar in both the groups. It was predominantly severe ARDS, so almost 80% of the cohort was severe ARDS. Our primary outcome was a composite outcome of the time taken to reduce oxygenation index by 50% and the time taken to extubation. And the results are pretty equivocal, so there's not much difference at all between both the groups. In either our primary outcome, which was a composite outcome, or in secondary outcomes like 28-day mortality, length of PICU stay, ventilator-free days. The only plus I would say is that there was no difference in healthcare-associated infections. In fact, the number was higher in the controls rather than the steroid group. But more children did develop neuromuscular weakness, although none of these reached statistical significance. So basically, we come back to my first point that we have steroid believers and we have steroid non-believers. So although I must say one thing, that while going through all of this evidence on steroids, the believers seem to have put in a lot more work into proving that steroids work than the non-believers who just went on to sort of say that, yeah, okay, the data looks like it's favoring steroids, but I don't think we can take it at that point of time. And this is something I think is a recurring theme. So even with the SCCM or the ARDS net or whoever it is, even if the guidelines do say that, yeah, maybe steroids do work, we are a little skeptical about following those things. All this has changed recently once COVID came into the picture, and suddenly dexamethasone is the hero of the day. So I'll just talk a little bit about this recovery trial which investigated dexamethasone. So across the UK, I believe it was 17 centers, and they randomized around 6,000 patients in a proportion of 2:1 to control to dexa. So that means 2,000 and odd patients got dexamethasone and 4,000 and odd got nothing. They just got standard treatment. And what they found is that in those who required oxygen, and those who required mechanical ventilation, dexamethasone reduced mortality by almost 1/3. But those who did not require any support at all, there wasn't much of a difference, but they do say that 1/5 of them never went on to require any further support. As a result of which now dexamethasone is center stage, and people all over the planet are talking about it like it's this new magic drug which we've never heard of before. Of course, all of us, I'm sure, are taking this with a little pinch of salt. Why does this work here? Is it just mitigating the inflammation that COVID causes, similar to what it would do in other settings? Or is it because it's a corticosteroid, like the way Dexa ARDS worked, and it's working in ARDS? I'm sure that we need a lot more studies, probably much better powered, much better planned, before we can say that this is actually the magic drug. Although now we see that people are using it left, right, and center. Time will tell us whether this is actually something real or not. So we come down to the final question of the day. And so would I use steroids in pediatric ARDS? So the theory and the rationale seem to be sound. Yes, there's dysregulated inflammation. Maybe steroids would mitigate that inflammation. Most of the studies, so even those which did not show mortality benefit, most of the studies showed lung injury improvement. In fact, even in our own study, we found that a higher proportion of children were extubated by day 14 in the corticosteroid group as against the control group, although this was not statistically significant. I think there was a difference of around 10% or so, but the numbers are small, so statistical significance was definitely not achieved. And it seems from most studies again that there seems to be no increase in incidence of healthcare associated infection or secondary sepsis anywhere, except for the influenza study in which they said that there was a 3 times risk that you're going to develop a nosocomial sepsis. So where are we going to use it? So shock may be a cohort where we need to use steroids. So as of now, we're still divided. Are we going to use it or not? So we just heard Dr. Kusum Menon's talk, and yeah, there is a lot of controversy on it, whether to use it or not. But shock may be a scenario in which we would use steroids in a child with pediatric ARDS. Pneumocystis pneumonia is one in which there are studies which definitely show that steroids do cause, faster weaning from the ventilator, better outcomes, better lung injury, improvement in lung injury. Any child with vasculitis who's already on steroids or has a suspected diffuse alveolar hemorrhage would benefit from steroids, so we would use it there. But here, it would probably be a higher dose as you would give a pulse. But if there's a suspicion and there's no confirmation, probably a low dose methylpred would work here as well. Now, pneumonia, yes, so pneumonia is something I have put in a gray box here because yes, it is a gray area. But there are studies which have shown, and these are studies in adults, in which they showed that if inflammatory markers, so we are generally scared of inflammatory markers and we equate them with a bacterial infection, but no, the fact is that they are inflammatory markers. So if inflammatory markers in pneumonia are high, so the one study, there was one study in community acquired pneumonia in adults in which they did a CRP at baseline, and if it was more than 150, they gave steroids and tapered it over 5 days. And they found that the risk of even mechanical ventilation, of getting ventilated, was lesser in those patients than it was on the others. So I am going to say that there may be a place for steroids in pneumonia ARDS. Now, if we take the influenza study and then decide to equate it here, so it's a viral pneumonia, would we give this there? So it's a retrospective study, so I do have my doubts as to whether to take it fully into account or not. But again, I would follow the same principle here. So if we are going to use inflammation as the marker, so if we have CRP, we could follow that. If we have the facility to do a BAL in the first week of illness, yeah, great, because many studies have actually followed the BAL, IL-6, TNF-alpha, and IL-1 beta levels and seen if steroids make a difference or not. And they found that inflammation is definitely mitigated in those who receive steroids. So pneumonia is definitely a gray area, so let's put a pin on that, but yeah, maybe. COVID-19, because of course, all the papers are saying that we should, but yeah, we do have to wait for more evidence on this, but as of now, practice-wise, yeah, probably COVID-19. And in children, so in smaller babies with associated wheeze, whom you would consider giving a steroid and otherwise maybe before they move on, possibly there is a role for this. Although again, there aren't any studies which have definitely checked those who have that wheezy LRI type of viral pneumonia versus those who don't, and whether steroids make a difference in that. Now, when are we going to start? So early is better. There is no point once fibrosis sets in, and virtually every study proves this. So the later you start, the worse is the outcome. So ideally within 72 hours, if we were to follow what Meduri did, or at least within the first 7 days of onset, so that we are hitting it during that exudative or proliferative phase rather than once fibrosis sets in. So the studied steroid is methylprednisolone at low doses. So it may or may not be preceded by a 2 milligram per kilo bolus dose, but otherwise it's a 1 mg per kg for 7 days, followed by a taper over the next 7 days, and it's as a continuous infusion. If the child gets extubated, we move on to the tapering dose. So as of now, our studies are all over 14 days rather than over 28 days. Of course, if the child gets extubated earlier, yeah, the course definitely gets shortened. Where would I not use steroids? So again, I put pneumonia in the last one. I'm putting pneumonia here again. So active sepsis or pneumonia. But the equipoise definitely continues, and DEXA ARDS seems to be a well-conducted trial. Oh, I'm sorry, I didn't mention one point about DEXA ARDS. They started steroids only after 24 hours, once they were certain that they had done everything to sort of stabilize that ARDS at that point of time. So they reassessed PF ratio at 24 hours before recruiting them into steroids or placebo. So I thought that was a pretty good way, the way Proceva did. So they gave them a period of stabilization before doing the intervention, because just the stabilization may make a difference. So, so with DEXA ARDS, yes, I'm on the fence again. Active sepsis pneumonia, do we or don't we give steroids? Immunosuppressed, unless they are on steroids already, or in PCP pneumonia. GI bleed, definite no, because the dose of steroids is enough to worsen that much more. Fungal pneumonia, it's going to worsen. And of course, one of the things we're all afraid of is that we would give steroids and lead to fungal pneumonia. And use with caution in children on neuromuscular blockage and other risk factors for critical illness neuromyopathy. So to summarize, it's still probably the most controversial of all therapies even today, even though it's cheap, even though it's easily available. We're still a little worried about using steroids, and I agree. I totally agree with the same point. No studies in children have proven mortality benefit yet. Many more randomized trials, well-powered, good sample size, probably multi-centric studies in a country like India are required. Dexamethasone may be a promising option because it's a much easier administration. It may or may not be a shorter course. We would need to decide on that. But the fact that it doesn't cause fluid retention may be something to think about. And if we are using steroids, I would say it's better to start early, and it's better to start low doses and then taper off slowly. Thank you so much for listening patiently.
So, thank you, Raj, for giving the wonderful lecture. And as expected, we have a lot of queries from the chat box, and I am going to push each one of the questions because we have enough time. I think we have 15 minutes. So first of all, I would like to clarify what I have understood, that we have to use steroids, then we have to use it early. Fine. So that means we have to use it within first 7 days, preferably maybe in first 72 hours after stabilization. You use the low tidal ventilation strategy with a PEEP titration. Fine. And also the PF ratio, which is less than 200, which qualifies for moderate ARDS. So here you have to start the steroids. Now the first question is, how do you use which steroid is better? Like dexamethasone versus methylprednisolone versus hydrocortisone? Is there any favored steroid which has to be used in the ARDS, and how do you go about it? So Raj, can you please answer this?
Okay, so most of the studies have used methylprednisolone in, so the ones that, I'll clarify this. So the ones that have used a design study protocol have mostly used methylprednisolone and mostly used the low dose that I was talking about earlier. So it's a 1 milligram per kg for either 7 days or 14 days and a slow taper thereafter. So total duration may vary between 14 days and 28 days in total. Dexamethasone, yes, we saw that it's been studied in adults in this DEXA ARDS trial. So I was looking at an equivalent dose. It would come to somewhere around 0.18. So let's round it off at 0.2 mg per kg per day of dexamethasone, which is again a low dose dexamethasone, which we could possibly use. So as of now, the evidence that we have would be in favor of methylprednisolone, but I would say DEXA seems to be a promising option, especially with its lower fluid retention capacity.
So as I understood, I also went through that DEXA ARDS paper, that where Spanish cohort is there, where they had done an analysis prior to just completion of the study, and they were surprised how much changes have come, and they never expected it. And 2-3 things which they have written very clearly is, it has got lot of anti-inflammatory properties, but less of mineralocorticoid activity, which obviously reduces your fluid retention, and that is very helpful. And the second thing is probably it is much cheaper. And third thing, which is very important, which is there is something called as auto tapering in dexamethasone, where sometimes you may use it for short bursts of 3 to 5 days, and because it is so much long lasting that by the days pass on, it itself tapers off, and you don't require such significant amount of tapering, which you have to do it in hydrocortisone or methylprednisolone. So but I understand there are no pediatric trials on dexamethasone in ARDS.
No, there aren't.
No. So my question is to now Dr. Arun Bansal sir, what kind of protocol you use in PGI and what are the cohort of patients which you would like to give steroids to, because you have got so many paper publications on that, and I think maybe you can help us understand whether we should use it or not.
Yeah, good evening, and thank you, Raj, for covering it very nicely, the topic. And you have taken us through for the pro and cons of using steroids. And practically, Raj has given the protocol of methylprednisolone, which he had used in her thesis, how we have been using, and that's what we follow in our patients also. We haven't used dexamethasone as such for ARDS. We have also used methylpred. And we try to start it early now, means that's what her protocol was. And that's what we have done. But we surprisingly did not find much difference, but maybe we needed a big sample size to find any significant difference in that. Compared to adults, in which there were many studies in which they had found remarkable difference with the use of methylprednisolone. But we have not found it yet, but maybe we need larger multicentric studies in that to find the exact difference.
Sorry to interrupt. Can you just put back a slide with the dosage, Rajlakshmi?
Sure. So please, Raj, do that.
Yeah.
And put
Yeah, for the first 7 days, and then we taper it subsequently.
I think that is the Madhuri et al. Protocol, which you have used.
Protocol, yes,
Yes.
absolutely.
So should I move on to next question? So that is a very interesting question. So once I was going through the adult literature, what they have done is there have been patients who have had at-risk ARDS or the patients who are falling into mild ARDS. And they have done some few of the biomarkers like CRP, procalcitonin. And once they have identified that, yes, they have the, by respiratory PCRs, the infection is either virus or bacterial, they have moved on to start dexamethasone. So can there be any choice like that once you know that there is a mild ARDS in a kid and you have high inflammatory markers or biomarker based therapy, which will be an individualized therapy? So will there be a time where you might have to start doing this even in pediatric age group? Because we know once they move on to moderate to severe ARDS, the outcome mortality is like very, very different. Fine. So outcome here is 70% in the patients of PADS in mild, but it goes to 40 to 60% in moderate to severe cases. So how do you go about it?
I think again it is like by the post 7 days when the fibrosis sets in, obviously then they have gone into severe variety. The steroids will not be working at that stage. Then the cascade has already set in. So the trick is to when to start. It's about how to start early, when to start, and it's to start early. So, and that is when the child is still in mild to moderate phase of the illness. So that is where we have to decide and start it. Regarding the biochemical based therapy, that if you can measure, obviously that is not practical in most of the centers, that you measure the cytokines and interleukins and then titrate your therapy. Like in the initial part of illness, we have seen that how the pro-inflammatory markers increase significantly, and in that earlier study of Madhuri et al., it has been shown that the survivors had decreased cytokines level and the non-survivors had persistently high cytokines level. So it makes sense, but then we need to measure it. It's not easy. Maybe it is only at experimental level or in a very big or corporate hospitals or big hospitals. Maybe they can try in that. But it is a fancy way of looking into it, and it's a very practical or scientifically way of looking at it. Yes, we can do that. Changing from which methylpred to dexa, again, we don't have any head-to-head trial in that. We don't know which is better and when it will work. Like dexa, methylprednisolone may have some fluid retention properties and all that. Maybe that is causing some, means dexa has got, maybe that's why got wonderful results in that. Maybe the next trials will be there seeing this effect of dexa in COVID. Maybe we'll have some good trials on that in methylpred versus dexamethasone.
If I may add a point here, one more thing is even, I mean, when we talk about inflammatory cytokines, even the large studies, for example, the ARDS net trials or whatever, less than half of the patients were fit enough to do a BAL. So BAL cytokines would probably be more effective than doing a blood cytokine level. But yes, as Ankit said, maybe using something like CRP to guide us with respect to inflammation and starting a steroid is something which we should explore.
So I think if we cover it with them appropriate antibiotics or maybe an antiviral, which as sir has told, it is not possible in everywhere in the country or in the remote places, then it becomes very difficult, because sometimes we only sometimes criticize that what was the need of starting these steroids, because we ourselves are not sure at what point it has to be started. So that is one thing. Now the another question is, does it help in drowning or maybe in the cases of trauma? Would you like to use steroids or would you just wait? Because what I have gone through all the trials, most of the 70% of the patients had sepsis and they had clear infection. So will you go ahead with this secondary ARDS role of steroids?
I don't have an answer for that question, quite frankly, because again, with the evidence that we had, and even in our own cohort, virtually everybody was an infection. It was just a question of whether it was a primary pulmonary infection or an infection elsewhere, sepsis and ARDS. So we did not have anybody with drowning or trauma even in our cohort. So I don't really have an answer for that question. But if we're thinking about inflammation being the primary thing, I think inflammation in these scenarios would happen slightly later probably. So no, I don't have an answer for that question, sorry.
So just why I've been taking care of this trauma unit, we also don't use it here. We don't have find enough evidence to use it. So the another question is whether will you use it in dengue ARDS or the scrub typhus ARDS, because now it is the season which is going to come. So they want to know in such kind of ARDS where you know that the typical ARDS doesn't last for more than 72 hours. There are fluid overload, other things which are causing it. So will you use it or no?
Okay, so I'm going to divide my answer into two parts. One is the scientific part and the other is the not so scientific part. So the scientific part of it is that in scrub in dengue, where it's predominantly the leakiness of the capillaries which is going to cause the ARDS, I don't think there's a role for steroids here. The role is of fluid deresuscitation and for the pathology. If we go on the principle that it's a vasculitis which is happening in both and maybe a low dose steroids is going to control the inflammation, that's a theory, but I think that's about it. The non-scientific thing is that, so this is scrub and dengue ARDS or one of those situations in which you would start the steroids and you would think that you have a miraculous effect. But the fact is, irrespective of whether you started the steroids or not, that ARDS would probably resolve anyway if the child was on the dipping side of illness severity. So I don't think that there is a role for steroids in either scrub or in dengue, unless there is an HLH along with it.
Okay. Sir, one question that once we are considering this early steroids, so are there any clear no's that we should not use early steroids? Will you highlight that no, we will not use steroids in these cases?
I think Raj has clearly put it specifically that these are the conditions in which we are not using any steroids. Like immunodeficient child, unless he is on steroids already, then we have like whatever conditions she has told, means clear-cut influenza or pneumonia, if it is there, we are not going to use it. These are the definite indications in which we are not going to use steroids. But yes, other conditions we may try.
So Raj, as we know, there are ARDS phenotypes like hyperinflammatory and hypoinflammatory. So people want to know whether they have been divided into hyper and hypoinflammatory and whether steroids have been used early versus late, and how did they have defined that the ARDS is persistent.
Okay. So one of the earlier studies by Anane was one of those studies in which they compared these different phenotypes. So they called them hyperinflammatory, hypoinflammatory. In the hyperinflammatory, they found those who had adrenocortical suppression and those who did not have adrenocortical suppression. And obviously the group which had adrenocortical suppression in the hyperinflammatory group were the ones who responded best to steroids. In fact, there was a significant mortality benefit in that group as compared to all the others. Now, we don't have that sort of a categorization for most of our patients on a daily basis. So we are not going to be able to say that this is a hyperinflammatory group and this is a hypoinflammatory group. If we're going to follow markers like CRP or, I don't know, fibrinogen or ferritin or whatever, in a sepsis, we expect most of them to be elevated. Now, we had not studied I mean, at least I have not substratified my analysis yet. In fact, we have not done we've not done a subgroup analysis of as of now, in which we divided them based on inflammatory markers or leukocyte counts or anything. So as of now, while we know that probably in a hyperinflammatory group it may work, but how do we identify that group? There are no answers to that as of now. So we would probably have to go by something like a CRP. But then, is there a difference? I think I'll have to analyze my data once and see if there is a difference between those two groups.
Sir, would you like to add anything in this?
No, I agree. It's very difficult to decide tell that which is the hyperinflammatory group. Sometimes even in severe infections, we don't have a significant CRP or ProCal. So we don't know what is playing behind that. They are culture positive sepsis, they have ARDS, but their CRP and ProCal are normal. So maybe we need some more definitive markers to tell us that this is a hyperinflammatory group, or there is some other biochemical or pathological changes happening in which these markers are not rising, but they are still having ongoing inflammation. So it's very early, or we are very naive at this stage to tell that this is hyperinflammatory group or this is hypoinflammatory group, short of measuring the interleukins and cytokines at present.
So probably we have Brahmastra, but we don't know how to use it, because we don't know, because still we think it is a magic bullet, but it is very difficult to be applied at the bedside. That how to use it, because
Raj, any studies are there in which they have measured the cytokines and seen the changes with the methylpred and in these groups?
Yeah, in both the Meduri studies as well as the Anane study, they had done BAL. They done BAL on day 3 and day 7. And they found that those who were on methylpred, they had lower levels of IL-6 as well as TNF-alpha on day 7 as compared to the placebo group. And this is one of the reasons why they say that steroids work in the inflammatory group.
So and with this improvement in cytokines, did they survive?
Yeah, they had shown a survival benefit in theirs. They had shown
with
a mortality
change
benefit.
in cytokines.
Yes.
Okay.
So now, sir, there are papers which are looking at genetics and the personalized medicine with biomarkers, which they have looked at IL-6, IL-8, interferon gamma, surfactant proteins, and that has all been helpful to guide them whether to use it or not. But as you have already told, they are very experimental level for us. So it may be very difficult for us to guide. So
genetics plays probably a very significant role in the pathophysiology of the disease, because same virus, same bacteria, maybe some kids behave differently and some have very florid course. So maybe there is something else also is going on along with it, and that is genetics and epigenetics both have a big role in that.
One last question from you, Rajlakshmi. So obviously we have a significant amount of malnutrition in our country. So malnutrition with ARDS and shock, what is your preference, hydrocort, how to go about it, or maybe use methylprednisolone? So that is one question probably you will have to answer, because a lot of the patients come as malnourished to us.
Okay, so I have very, very limited experience, and my experience is actually limited to this thesis. So in my thesis, it was very well defined that we are going to give methylprednisolone to all those who have ARDS and who don't meet any of my exclusion criteria. So malnutrition was not an exclusion criteria. So we gave methylprednisolone to everybody. Now, but yeah, the point is very valid, because we suspect that there is some degree of adrenosuppression in children who have malnutrition. Now, they may not be able to mount the stress response that other children would. So they would tend to have a suppressed HPA axis, and there probably supplementing steroids theoretically would help. Now the question is that actually going to help in practically? Because this is the same argument which we follow everywhere. Again, I have not, like I said, I've not done any subset analysis as of now. So yeah, but I was planning to do an analysis based on weights for age and see if there is a difference in outcome in those who received steroids and didn't. So as of now, I don't have an exact answer to that. So again, theory, rationale all seems sound. Practically, is it going to make a difference? I don't know.
Any final word from you? So final concluding remark as an speaker for the role of steroids finally in ARDS, where like we want 5 points, clear 5 points. Yeah.
Okay. So if you're going to use steroids, so again, like I said, you would need to choose a side to stand on. Do you think steroids are going to work? Don't you think they're going to work? If they are going to work, There are certain scenarios where we could use them. So in any scenario where there is an uncontrolled inflammation, so a pneumonia, a sepsis, if we find that inflammatory markers are high, we probably could use it. Like I said earlier, in shock, in septic shock, in diffuse alveolar hemorrhage, vasculitic syndromes, in most of these conditions where the HPA axis is involved, steroids are probably going to be beneficial. So first decide whether you're going to give it or not. If you're going to give it, do not wait for 7 days before you give it. Try to give it within the first 7 days, if possible within the first 72 hours, and give it quickly. As of now, methylprednisolone will be our preferred drug. Give it as a low dose and give it for a prolonged period, because the stoppage of steroids has been associated in studies with adverse outcomes, including mortality, readmission. So it's always better to do a slow taper than to stop it immediately. Dexamethasone is something I think we should start exploring. And we would probably, in a country like India, our cohort is extremely different from all pediatric ARDS all over the world. So in parts in the world, the mortality in severe conditions, they're saying is somewhere around less than 20%. In our country, severe ARDS mortality varies between 45 and 65%. So in ours is a totally different ballgame. We cannot extrapolate Western data to us. So we would probably need to do some kind of a multicentric study and create our data on whether steroids are going to work for us or not.
Thank you so much. Sir, would you like to add anything?
No, I think it has been well covered. I think done. Good job.
Okay, thank you so much, sir. And obviously you have given us a beautiful insight, and thank you, Raj Lakshmi, for the wonderful presentation. And next presentation is on Saturday, which will be on community acquired pneumonia, the intensivist perspective. So that will be the speaker will be Dr. Nitin Dhochak, who is from AIMS. So we look forward for that session. Thank you.
Thank you, everybody. Thank you all.